Good evening, everyone. Good evening, and welcome to the first Ethics of Care series hosted by Community Memorial Hospital. My name is Dr. Jim Hornstein, and I am the chairman of Community Hospital's Bioethics Committee. And it is truly an honor for me to moderate tonight's first of two lectures on the hugely important and topical topic of healthcare reform in America. So first of all, thank you all so much for coming tonight. On March 23rd, 2010, about 3.5 years ago, President Barack Obama signed into law the Patient Protection and Affordable Care Act, now commonly referred to as the ACA or Obamacare. Now, if we go back for a second to 2010, so put ourselves back about 3.5 years ago to a time just before the passage of the ACA, former President Bill Clinton made an important prediction. President Clinton said, and I quote, "The minute President Obama signs the healthcare reform bill, its approval will go up because Americans are inherently optimistic." Now, can I please see a show of hands for those of you in the room tonight? How many of you feel inherently optimistic? The lights are down. I don't see a lot of hands. Now, I'm very reluctant to criticize a former president, but I'm not sure I would characterize in 2013 in October the current mood of our country as being overly optimistic. I would, however, characterize our mood as concerned, skeptical, partisan, and maybe even a little bit confused. And with all the many controversies and disagreements about Obamacare, I do think that most Americans, in fact, as of this date, can agree on 2 points, which I think is rather remarkable. We can agree on virtually anything. And the first point I'd like to make is this, that the Affordable Care Act, or Obamacare, is the most important piece of health-related legislation in over 50 years. In fact, not since the legislation that brought the passage of Medicare around 1964. And some observers have noted recently that Obamacare, in fact, may be the most sweeping health-related legislation in all of American history. My second point I'd like to make is that Obamacare, or the ACA, will almost certainly affect the lives, the well-being, and the pocketbooks of every man, woman, and child living in America. And what's more, it will affect us in many different and various ways. For example, it will definitely affect young people just starting out in their lives and their work much differently than older people who are nearing retirement. And what about its effect on currently uninsured Americans? What about on employers? What about those already who have health insurance? What about those who are already on Medicare or Medicaid? Another question which has been worth considering recently, how will Obamacare change the way doctors and hospitals take care of us now and in the future? And another important question which we still do not have answers to, will my insurance rates go down while the quality of my health care goes up? Or will it be the other way around? Ladies and gentlemen, we selected the subject of examining Obamacare not because it is easy, which of course it certainly is not, but because it's important. It's important because, let's face it, all of us and all of the people that we love will at some point become patients, and we all want to receive the right care at the right time, and frankly, at the right price. So again, thank you all for coming tonight and for giving us the opportunity to help sort out and clarify the important issues for both our Ventura and regional community and also for our nation. I'd also like to thank the Board of Trustees and the administration of Community Memorial Hospital for graciously sponsoring this important series. And finally, I'd like to single out two individuals who are absolutely instrumental in making this program happen. The first is standing off to the right, Mike Ellenson, who is the Vice President of Marketing and Development for Community Memorial Hospital, and Mary McCormick, the Manager of Marketing, who most of you met when you came in. They were absolutely delightful to work with throughout this entire process, and we owe them a great deal of thanks. And now it's my great pleasure to introduce tonight's keynote speakers. For our first speaker, he will lay out the groundwork for our entire series and explain why our country needs healthcare reform in the first place. He will be followed by our second speaker, who will present a practical summary of the key elements of Obamacare or the Affordable Care Act. Following their prepared remarks, we will have time to pose questions to our speakers, so that if any of you can think of a question while they're speaking, please write it down on an index card, which we will be passing out, and hand it to one of the ushers walking around the room. Okay, so now let's begin. It is my very great pleasure to introduce our first speaker, Mr. Gary Wild, who is the President and CEO of Community Memorial Health Systems. Mr. Wild earned his Doctor of Health Administration from the Medical University of South Carolina in Charleston. He also has a Master's of Health Services Administration from Arizona State University in Tempe. He obtained his Bachelor's of Arts from Brigham Young University in Provo, Utah. And Mr. Wild is a Fellow of the American College of Healthcare Executives. Ladies and gentlemen, please help me welcome to the podium the President and CEO of Community Memorial Hospital, Mr. Gary Wild.
Thank you, Jim. It's a delight to be with you today, and also Dr. Kaminsky here later on. So I'm going to start by talking about what brought us here. Why do we need health reform in our country and at this time? There are four compelling reasons. The first one is economics. I'm going to go into some depth on that. Secondly, demographics. Thirdly, we have large variations in our lifestyle and therefore our health outcomes throughout the United States. And that's different than most other countries. And finally, we have an issue with access. Not everybody can purchase insurance or have insurance, and the number of physicians that are available in communities is disproportionate. So the economics, I want to start with this somewhat familiar slide that you've seen before, but the United States spends far more money than any of the other countries you can see in the slide. And what's more, we don't get, in return, better outcomes measured by life expectancy. You can see here the United States spends between $7,000 and $8,000 per individual in healthcare. The life expectancy is 70. And you can see all other countries, beginning with Switzerland down to Spain, their life expectancy is actually longer. We're going to talk a little bit more about that, but remember this number right here. In terms of healthy life expectancy, it's a little different from total life expectancy. When you put all that together on a matrix, we find that this is a comparison with health spending versus life expectancy. And you'd expect that the more you spend, the higher life expectancy. But in fact, the United States sits over here. It spends far more money, but it does not have life expectancies that are higher. We're also, those that are my age remember Popeye, and we have we're a nation that really is a borrowing nation. I'd gladly pay you Tuesday for a hamburger today. Was that Wimpy? Is that his name? Okay, Wimpy. Well, when we look at it, the United States today spends, it borrows 46 cents for every dollar that it spends. That's remarkable. Every dollar we spend, 46 cents is borrowed. And it's borrowed from those that buy T-bills, it's borrowed from foreign governments that buy this, and this is a concern. Now, healthcare is a factor in that, but the U.S. spends, has now debt higher than any other country on a per capita basis. $53,000 of debt is when you divide up the number of people living here. We are far more than Greece or Italy or any other country. We have a greater amount of debt per capita than any other nation in the world. Fortunately, our gross domestic product is greater than any other nation in the world. And we have, in World War II, the amount of debt that we accumulated was approximately 100% of the gross domestic product at that time. And over the succeeding years, it went down, and now it's starting to approach that same level again. The concern is that when you reach this level here, it's a point of no return. Greece is in that situation, and other European countries. Now, looking at it a little bit different, the same data, a different forecast is if we were able to control our spending, particularly in healthcare, could we make a bend of that curve? Instead of this curve here that's going out of control, could we in some way bend that cost curve? And this is what largely is debated back and forth. This is what the whole debt ceiling limit debate was last week and the weeks before. Can we afford a system where we're spending more and more money and the national debt continues to rise? And of course, healthcare was part of that. In the United States, we now spend almost 18 cents of every dollar we spend is in healthcare. It's stabilized at this level for the last several years, but think of that, 18 cents. Some argue that that is way too high. Automobile manufacturers who compete with foreign markets, Ford, Chevy, would argue that they are having to spend far more money. You know the statistic, you've heard this before, that Ford spends far more money in healthcare for every car than it does in the steel and the glass and the electronics. And this is putting them in a way in a anti-competitive situation compared to BMW, compared to Mercedes that spends far less. We also, at a very personal level, roughly today, a household income of $75,000 spends $19,000 for premiums and out-of-pocket expenses. If that were to continue, we would be in a situation in 2020 where that same family, adjusted for inflation, would spend approximately 45%. This, of course, is untenable. This can't continue. Nobody will be able to afford that. So there has to be a reduction, a bending, so-called, of the cost curve, that we cannot afford it. It's also interesting to look at this. I call this the hockey stick slide. You can see we've selected here 4 other countries, Germany, the UK, Sweden, Spain. And in a future session, we're going to talk about the other healthcare systems of those nations. Tonight, we're not going to spend much time on that at all, except to say that the United States spends a similar amount of money for 10-year-olds, 20-year-olds, 30-year-olds, all the way over until almost 60 years old, and then it skyrockets up. And this is where the significant spending in the United States happens compared to other countries. Another factor is, can we have this continue to go on? This is a graph that shows from the Medicare Trust Fund and also Social Security. The blue line is Social Security, and it's estimated that it will go bankrupt, all things being equal, around 2035. And this line right here is Medicare. And Medicare was projected to go bankrupt, going down like this about 2017. And with the implementation of Obamacare, some believe that that can be postponed, but it still is a vulnerable program unless expenses are curtailed. Putting this all together, economics is a major reason where health reform was necessary, or at least most people believe that. Also demographics. We're getting older, and our nation is increasing actually the number of those aged 65 and older, and particularly those that are 85 and older. In 1965, when Medicare Title 18 and Title 19 of the Social Security Act were passed, there were approximately 18 million over the age 65. Today there are 58 million and climbing. And this is a big issue with the retirement of the baby boomers going from the working ranks to the retirement ranks. As they graduate to the retirement ranks, they're paying fewer taxes, and they're also going to be taking a benefit. And so this is really a collision course. For our area here, Ventura, Western Ventura County, you can see that between 2010 and 2017, just those years, the Medicare population, 65 and over, goes up by 20.1%. That's the fastest growing segment of our population. I'm going to switch to lifestyle and variation. We have an unusual situation compared to other countries, call it Spain, Germany, and so forth, where average life expectancy is similar. There are variations, of course, by region, but it's similar. In the United States, there is significant variation. The darker, the longer the life expectancy. And as Jim indicated, I did my doctorate work in South Carolina, and we studied a lot. Why is it that the Southeast has a lower life expectancy? And it really comes down to issues of diet and smoking, high salt content, high fat content, and so forth. But be that as it may, this is a concern. In Ventura, by the way, in Ventura County, we are in the top, I don't know what I did, but I did something. We're in the top 5%. Actually, we are at the top 2.6% of all counties. There's 3,007 counties in the United States. We're number 80 in life expectancy. So we're doing far better. And our life expectancy for men is 78.1 years, and for women 82.6 years. And we also look at life expectancy once we reach the age 65. So if we reach the age 65 in the United States, we actually have a long life expectancy. The numbers are skewed because of some other factors with younger people. But if you're a man in California, your life expectancy is, once you reach age 65, you're going to have another 20 years. And as a woman, you're going to have another 21.5 years. That changes the statistics a little bit. But look at this. In California, healthy life expectancy, this is a measurement we don't have time to go into, but quality life, being able to function on your own and be able to get out and so forth, quality life expectancy after age 65 in California, women have an additional 15 years, and so a quality life through the age of 80, men 78.8. But when we go to Mississippi, that number is 10.8. Half the number. We're not quite half the number, but you see my point there. Significantly lower. So when we compare ourselves, and this is a hard slide to look at, while it's true that our life expectancy in the United States is less than other countries, you can see, for example, up here, we're way up here in a very, very high percentile in Ventura, we're among the longest life expectancies in the world. Where we also compare to Mississippi, down here, they're among the lowest. So the point here is we have wide variability. We have the medical science. We're the envy of the world in terms of our medical knowledge, but we have problems. One of the issues for us is obesity, and obesity is connected with diabetes and other health risks. In 2011, they did a survey that is somewhat subject to interpretation because it's self-reported. I don't know about you, but I don't really write down exactly what I weigh, but they asked people to be honest. But in 2011, you can see California was not that bad, but approximately 20 to 25% of our population was obese. That's a high number. But compared again to the southeast, where over 35% were obese. Now, most of the country actually did better the next year, but California didn't. We went up over 26%, while most states did better. So, lifestyle. We could also put slides up here with smoking. We could put up blood pressure or uncontrolled blood pressure and so forth. There are things that a health system can do to prolong life and to focus on wellness. Dr. Kaminsky will talk probably a little bit about that emphasis of wellness and prevention instead of sickness care. So also another issue is infant mortality. And the United States has an infant mortality rate of about 6 per 1,000. Singapore has a number of about 2 per 1,000. Sweden, 2.1 per 1,000. Now you'd think, with all of our medical knowledge, that we would be right in there. And this, again, is somewhat skewed. California has a number of 4.8. Ventura has a number of 1.8. In other words, the community moral health system, the number is 1.8 per 1,000. So again, the distribution of physician medical knowledge and how we prevent illness is a major issue. And the theory is, if there was a better coordinated health system, we could drive this rate. We could drive life expectancy to more favorable levels and make it more consistent. And therefore the argument that variation is part of the issue. We also have variability in the supply of primary care physicians. California is blessed largely with great physicians. It's a great place to live. We have great universities that produce physicians. But you can see again how the Southeast is underserved, and maybe there's a connection. And this so it shows the same type of slide where we are pretty well served. That was all physicians. Now this is an interesting statistic that I thought would be somewhat of a capstone. 5% of the population of the United States spends 50%, 49.5% of all the cost. So 5% is the old 49.5 rule you're familiar with. That's supposed to be a joke. 5% spends 49%. And half of the population, fully half the population, spends only 2.7% of the healthcare dollar. Therefore, a health system which is more coordinated would be able to proactively look at those individuals who are at greatest healthcare risk, diabetes, congestive heart failure, other chronic conditions, and intervene earlier to try to spend less money over time. And this just shows it graphically that the top 50% spends 97.3%, the bottom 50% 2.7%, and you can see the top 1% spend 21%. 1% of our population spends 21% of our healthcare dollars. 10% spends 65, 2/3. And that's really an amazing statistic. You won't find that in other countries that have a more coordinated program. Finally, access. We have a lot of uninsured, and that was one of the goals of the Affordable Care Act, to increase insurance. California is right here. You can't really see the colors that well, but we have about 14%. It used to be 16% a few years ago. 14% is uninsured. In our area, our density of uninsured is pretty high, actually, here in Ventura. And when we look at coordinated care, comprehensive Medicaid, we call it Medi-Cal in California, we're pretty high in that, where we actually, rather than just having episodic care, treating people in emergency rooms, we coordinate the care a little bit better. And in Medicare, the statistic is 37% are involved in a Medicare managed care program. We also have wonderful fee-for-service programs. While we are better off than other states, we're far from ideal. There are physician shortage currently, and there's many who call the hospital wanting to identify a good primary care physician. Some are not taking Medicaid, some are not taking Medicare, and we'll see a growing shortage. In fact, one of the things that causes that, over time, even though we have a growing population and an aging population, the number of medical school graduates has plateaued since 1990, roughly. It's gone up just slightly about in the last year or two. This will result in a worsening physician shortage. And over time, by 2015, around the corner, it's estimated that we'll have 62,900 physicians fewer. By 2020, 91,000. By 2025, 130,000, unless we do something. We can train more mid-level practitioners, nurse practitioners, PAs. We can increase the number of graduating medical students. We've just launched, I see Aaron here and others have just launched a graduate medical education program. So Ventura is going to grow its own, and we are going to resupply our population that way. So we're looking at a greater population. We're looking at a increase in demand and fewer physicians. And in summary, the reason that we need to do something is the economics are unsustainable. We have an aging population. We have a high degree of variation throughout the United States, and shame on us because we know how to treat disease better than we are, or shame on us because we're not doing all that we know that we should be doing to take care of our health. And we also have limited access for many and fewer physicians in the future. So I just wanted to give that backdrop of why health reform is an issue, why we needed to do that. And I'm going to turn the podium back to Jim, who's going to introduce our next speaker.
So did you get all that? Gary, that was terrific. What an amazing overview of a very, very complex topic. Thank you very much, Gary. It's another great honor for me to introduce our second keynote speaker, Professor Jerry Kaminsky. Dr. Kaminsky received his PhD in public policy analysis from the University of Pennsylvania's Wharton School and his bachelor's degree from the University of Chicago. Prior to joining the faculty at UCLA, he served as a staff member of the agency known as the Medicare Payment Advisory Commission, or MedPAC. He is co-author of over 120 articles and reports and co-editor of the widely used textbook, Changing the U.S. Healthcare System, Key Issues in Health Services Policy and Management. Ladies and gentlemen, it's my very great pleasure to welcome to Ventura a fellow Bruin, Professor Gerald Kaminsky.
much, Jim. It's a pleasure to be here tonight to talk to you about Obamacare and the Affordable Care Act. So I was asked to talk about, in a general way, what is in the law, what's the basic structure of Obamacare. So that is what I'll spend the next 10 to 15 minutes doing. So Gary did a good job of providing an overview, and although I hadn't seen Gary's presentation previously before tonight, I give a similar talk and have over the last 3 years, sort of providing the motivation for why do we have this law and this particular law? What are we trying to accomplish? And not surprisingly, I use a lot of the very same slides that Gary presented. But the one piece of information that I want to emphasize is, and I think more than anything, is that the Affordable Care Act, the primary rationale is that too many people fall through the cracks of the current health insurance quote-unquote system. The current figures are nationally 48 million Americans are uninsured. In California, based on data that we collect at the UCLA Center for Health Policy Research, 5.8 million Californians, as of right now, have no health insurance. The Affordable Care Act is primarily intended, it's trying to accomplish many things, but it's primarily intended to reduce the high rate of uninsurance in the United States. Now, it does that by expanding access to existing insurance programs rather than redesigning the entire insurance system. So this is an incremental reform. It is not a fundamental reform of the healthcare system. We've heard relentless attacks over the last few years about what this law is trying to do. The reality is, and we've heard very extreme language used in opposition, it is a very moderate reform. It is a reform that, if we sort of go back in time and look at the origins, the most recent origin is Romneycare in Massachusetts. That was the blueprint for Obamacare. I know in the presidential debate there was discussion about whether or not it really was the same law. Ladies and gentlemen, it's the same law. It's essentially the same thing. There are minor differences between what Massachusetts implemented in 2006 and what the US is in the process of implementing, but there are very minor differences. But we can trace it back even further. In the mid-1970s, Professor Alan Enthoven from Stanford University outlined a proposal for reforming healthcare in America. And he called his approach managed competition. But the basic principle was that we would enroll people into purchasing cooperatives. Those purchasing cooperatives today are called exchanges. He said for people who can't afford insurance, the government should provide subsidy. And we should encourage competition between health plans within these purchasing cooperatives using standardized insurance products. So the ideas and sort of the conceptual outlines for this approach. And by the way, Professor Enthoven, not only given the fact that he's in a school of business, but his proposal was viewed as a very market-friendly and market-oriented solution to some of the problems with the US healthcare system. So that really is the sort of the origins of this approach. The law also provides federal funding to expand access to insurance while allowing considerable state variation in implementation of the law. And this approach to federal legislation is known as the new federalism. And this concept has been around for more than 30 years, but the idea is that rather than developing a single government program at the federal level and adopting and administering the program solely at the federal level, that the federal government works in partnership with the states to account for the fact that there are regional differences in the United States and to allow for significant state participation. We could talk in the Q&A about whether or not that was led to more trouble with regard to this law or not, but the fact is that the law was designed to allow significant state participation in the implementation. And the law expands access to private insurance markets. Now these insurance markets, as I'll discuss in a few minutes, are now subject to extensive federal regulation, and this is for the first time in our history. We've never regulated health insurance products this extensively at the federal level. It's largely been a state responsibility prior to the Affordable Care Act. And the bargain that was struck is that in exchange, the insurance industry more or less willingly went along and did not oppose this law 3 years ago, because in exchange for the new regulations, they would be getting subsidies to enroll as much as 32 million new customers in largely private insurance markets. And I'll talk about the Medicaid and Medi-Cal expansion in a minute, but even the Medicaid program in most states is largely administered by private insurance companies. So let me talk about, just for a few minutes, the broad overview of the major elements of the bill. As Jim said, it's the Patient Protection and Affordable Care Act. And I think that it's important because it's sort of, the title of the law captures the major objectives. First, let's talk about the Affordable Care component. That is designed to reduce the number of uninsured, starting in January of 2014. And there are three major components of the law. There are mandates, which are designed to prevent cost shifting and quote-unquote free riders from opting out of insurance until they need it. Now, this is the most controversial aspect of the law and was the subject of the constitutional challenge that was brought against the law and that the Supreme Court acted on last year. But without the mandates for individuals to buy insurance, if we open up the market and tell insurers that they must accept all risk, that they must guarantee issue of insurance to anybody that wants it, we want to avoid a situation where people opt out until they get sick. So the idea is to have as broad a participation as possible. With social insurance programs like the Medicare program, we guarantee universal participation because that's the way the system is funded. We deduct Medicare, we finance Medicare, at least Medicare Part A, through payroll deductions. So everybody participates, everybody pays in. There's not really a question of being a free rider. We are required to do that. But this law took a different approach. So the mandate, in a sense, substitutes for the requirement that we pay payroll taxes to finance the law. But if you're going to require everyone, or virtually everyone, to have health insurance, then you've got to provide subsidies because health insurance is not affordable, particularly for people at middle and especially at lower income levels. So the law provides subsidies to low and middle income individuals so they can comply with the mandate. I'll talk about that a little bit more in a minute as well. And then finally, the third major component is this idea that I alluded to from Alan Enthoven, which is that we need to create regulated markets. If we require everybody to buy insurance and we provide government subsidies, we better well redesign the insurance market so that insurers don't take advantage of the fact that people are now coming in with subsidies, but insurers can continue to do business the way that they do today, which is to charge you a higher premium if you have a pre-existing condition, to exclude you and deny you coverage if you have certain pre-existing conditions. So regulation of the insurance market in these exchanges was the quid pro quo that insurers accepted. And this is really to prevent insurers from doing risk selection, basically cherry picking low cost patients, relatively healthy patients, at the expense of people who are sicker and therefore higher users. And the one slide that Gary used, I thought was an excellent illustration of that. You can see 50% of the population accounts for about 3% of total spending. Well, that's the market that insurers want. Basically people who are going to be low users, and you can make insurance very, very affordable for 50% of the population if you can find a way to just capture that part of the market and leave all the really sick people out of the market. And we sort of do that today. The patient protection components of the law are things that have been in effect for a few years that actually benefit everybody with insurance, virtually everybody with insurance. but they're some of the least well-known aspects of the law. So there are new protections that are in place that I'll talk about very briefly in a minute. We've eliminated pre-existing condition exclusions for children as of 2010, and that goes into effect for adults starting next year. And we also now provide protection as a result of the system of subsidies for people who lose their health insurance through their place of employment. I'm going to just talk quickly about the individual mandates and the subsidies. Starting next year, unless this gets delayed, and I say that there's, based on sort of current developments and problems with the federal website in particular, healthcare.gov, and the statements within the last few days that that website will be fixed at the end of November. I think that as a result of that, there's a possibility, more than a slim possibility, that the first element here on this slide might get delayed. And the reason for that is that if you're compressing an open enrollment season down to basically the last week of November, the first 2 weeks of December for people, and penalizing them if they don't change their insurance during that narrower window, that's sort of contrary to the spirit of the law. And as a result, it's possible that this penalty might get delayed for a year. But starting next year, and I don't have it in the slide, the penalty starts next year at $95 per individual and up to 1% of family income. And it will increase by 2016 to the amounts that are shown here, which would be $695 per adult, $285 per family, or 2.5% of family income. This was the provision of the law that was decided by the Supreme Court, and that the court held was in fact constitutional, that it was within Congress's taxation authority to impose a tax penalty on people who were not insured. The law provides subsidies for people up to 400% of poverty, and I realize that I do a lot of public speaking on the law. Almost everybody knows their income within $1,000 or so. Nobody I've met knows where their income stands relative to the federal poverty level. And it's because it's a function of not only your income, but your family size. And it changes for every additional member of your family. So I've just, at the bottom of the slide, included two pieces of information. For a single individual this year, the poverty level is about $11,500. 4 times that, or 400% of that, is roughly $46,000. For a family of 4, the poverty level this year is $23,550. So for a family of 4, 400% of the federal poverty level is about $94,000. So the law has subsidies for people roughly between 139% up to 400% of the federal poverty level. The amount of out-of-pocket spending that people will be responsible for is also graduated between those two levels. So at the low end, you would people will be expected next year to pay 2% of their income, going up to as high as 9.5% of their total income. And then the subsidy would cover the rest of the cost of a silver plan. And I'll talk about what that means in just a second. The law also expands Medicaid for everyone below 139% of the federal poverty level. Now, this is the provision of the law that was found to be unconstitutional by the Supreme Court. And it wasn't the expansion per se, it was the mandatory expansion. The law originally said that states had to expand their Medicaid program to this level, or they would lose all of their Medicaid funding. The court found that this was excessively punitive, and as a result, the solution was to make the Medicaid expansion voluntary. As a result, 26 states currently are not planning to expand their Medicaid programs. And so for people below 139% of poverty in those states who don't qualify for Medicaid today, those individuals will literally be left out in the cold next year. There is no relief, there's no option for those individuals to go in and get exchange, to go into the exchange with subsidies. I mentioned that there are regulations that are currently in place. These don't get a lot of discussion because the fact is, and that most of these don't affect a large percentage of the population. These are protections that are in place when something really goes wrong for the most part, with the exception of the first one on the list. The law expanded coverage for adult children up to age 26, and although it was common in the marketplace for insurers, particularly large insurers, I should say large firms buying insurance for their employees, to offer extended coverage to adult children. Usually that stopped at age 23, and it generally required financial dependence on the parents. The way the law reads now, it's up to, but not including, it stops at age 26, so it's through age 25. And more importantly, your child does no longer needs to be financially dependent on you in order to stay on your policy. And this has resulted in a reduction of about, or I should say an increase in the number of insured Americans by about 3 million nationwide. The law eliminated policy cancellations, it eliminated lifetime dollar limits on benefits, it provides coverage for appropriate preventive services for free. It eliminated the pre-existing condition exclusions for children under age 19, and it is in the process of phasing out annual dollar limits on benefits. The law also creates, starting next year, standard insurance policies in the individual and small group market. Let me just, I don't have this in my slide, but right now, the vast majority of Californians and Americans, most people get their health insurance through their place of employment, which covers workers as well as dependents. In California, about 19 million people get their health insurance this way. Except for the provisions that I just talked about in the previous slide, most of the ACA does not apply to the large group market. So anybody who's getting their health insurance through the large group market, now there are changes going on in that market all the time. The UC system is a good example. This year, the university has decided that Anthem plans are no longer cost-effective options and decided to drop all Anthem plans from the UC system. This will affect approximately 1/3 of families and individuals covered by UC insurance policies. But this has nothing to do with the Affordable Care Act and everything to do with employers trying to keep cost as low as possible and looking for the lowest cost alternatives. So the Affordable Care Act is really targeted at the individual market where people buy insurance on their own because they don't get it through their place of employment or because they're self-employed. And the small group market, which is for firms up to 50 employees. And that's the market that the ACA is targeted. But the subsidies and most of what I'm talking about tonight really affects the individual market. So starting in January, and it's actually now, this is what's being sold through the exchange, which in California is known as Covered California. The law establishes qualified health policies that all have the same essential health benefits. And I'm going to show you what those are in just a second. In addition, the law establishes 4 metal tiers of these qualified health plans based on actuarial value. And what is actuarial value? Well, it's a concept that basically just measures how much of the plan's expenses are captured by the premium payments versus the out-of-pocket payments that you make when you use care. So the 4 levels are bronze, silver, gold, and platinum. You've probably heard these. There's also a catastrophic plan available to young adults. But let me just focus on those 4 metal tiers. So the bronze plan is intended to be the most affordable on a monthly basis. It has the lowest monthly premium, but the highest out-of-pocket liability. So this might be a good plan if you're relatively healthy and have low use. You can minimize your monthly payments, and when you use care, you're going to be spending more. You're going to have higher co-payments and a higher deductible. But if you don't use much health care, this could be a bargain. The platinum plan is just the opposite. The platinum plan, you're going to pay a lot more on a monthly basis in the premium, but when you use care, you're going to have much lower co-payments. The essential health benefits. All of these plans that are going to be sold inside the exchange and outside the exchange, and this is important, both in and outside the exchange, are going to be are going to have essential health benefits, and will have to be one of the 4 metal tiers. So the essential health benefits you can see here, this is in the federal law, and this is what all health policies need to have coverage for. Now the first 4 categories on this list are pretty common. I think most people think of health insurance as covering ambulatory care, emergency care, hospitalization, lab services. But it's when we get further down the list, especially in the individual market, where policies today may or may not cover these services. And one way to keep the cost of the policy down is, for example, to offer a policy without prescription drugs. And if you don't have if you don't have a chronic illness that's being managed with a prescription drug, this might be a good option for you today. But next year, that's not going to be an option, a plan without prescription benefits. Policies in California until a few years ago excluded some policies, about a quarter of the policies in the individual market, excluded maternity benefits. You can imagine these were marketed to young men and to older adults who were past childbearing age. It's a way to save money, but it meant that policies for young women were much more expensive because they were the likely users of these services, and we weren't spreading those costs over a broad population. This is just a brief illustration of the differences between the 4 metal tiers. And as I said, so if you look at the bronze, it has a $5,000 deductible. This is a high deductible plan. We generally characterize high deductible plans today in the marketplace as $1,000 deductible. This is a very high deductible plan. And you can see the co-payments just for select services. This isn't the full range. $60 per visit for a primary care visit. $19 for a co-payment for a generic medication. That's after you meet the $5,000 deductible, because it also applies to prescription drugs. So you're going to spend a lot of money out of pocket with a bronze plan before, in a sense, your insurance kicks in. But you also have a cap on your annual spending though. It's $63.50 for an individual, or $12.7 for a family. So there is a cap on how much you'll spend out of pocket. But this is very much like a catastrophic plan. The Platinum is just the opposite. Again, higher monthly premium, but no deductible, $20 co-payments, $5 for medication, and a $4,000 annual limit on spending for an individual and $8,000 for a family. So much more sort of insurance here and lower out-of-pocket spending when you use care, but you're paying much higher premiums on a monthly basis. Now, where are these new policies going to be sold next year? They're going to be sold in the exchanges that have been established around the country. In California, our exchange has covered California. We're one of 14 states that have a state-run or state-based exchange. Many states, partly out of opposition to the law, decided not to create their exchanges, and by default, the federal government has to establish the exchange in those states. And you know, over the past 2 weeks, you've been hearing a lot of news reports about the problems with healthcare.gov, which is the federal website for shopping in those 36 states. I'm not going to go into those, but I'm happy to talk about that during Q&A. In each state, there needs to be an individual and a small business exchange set up. The exchanges can only sell qualified health plans with essential health benefits. And as I mentioned earlier, they have to be sold outside the exchange as well. And the reason for that is to prevent insurance companies from trying to cream, skim, and segment risk. There was a great deal of concern that the exchange not become the dumping ground for poor risk or high cost patients and allow insurers to just serve low-cost, healthy people outside the exchange. So that's why the same policies are being sold. Insurers can set premiums based on what's known as modified community rating. They can use age, tobacco use, family size, and geography in order to set premiums. Now in California, we are not using tobacco use as a basis for setting premiums, but age, yes. Family size, yes. Geography, yes. There are 19 market areas in California for selling policies. But health status can no longer be used as a basis for setting premiums. Not only are insurers required to offer insurance to anybody who is willing to pay the premium, but they cannot charge more based on your health history. In fact, they're not allowed to take your health history in order to sign you up for coverage. The last point on here is that the individual and small group markets continue to exist, but they're subject to the same rules as inside the exchange. And if an insurance company sells a policy in the exchange and outside the exchange, then it has to charge the same premium for that same policy. So if, just for example, Anthem sells the bronze plan in the exchange, also sells the bronze plan outside the exchange, that same bronze plan, then it has to charge the same premium, both in and outside, again, to prevent cream skimming. Just to get to the end of my presentation, this is the website. This is Covered California's website. Whether you're shopping for insurance, whether anything that I've said tonight affects you, I recommend you go to the website and see what it's like to shop for insurance. It is generally a user-friendly experience, although I cannot honestly stand here and say that this website is glitch-free. It has had its own problems. I don't think they're nearly as severe as the federal website, but I particularly call your attention to the Shop and Compare tool, which is in the middle of the screen. Unlike the federal site where you have to establish an account and provide lots of information in order to set up an account before you can shop for policies, in California, this is more like Amazon.com. You can go onto the website, you can look at policies that are sold in Ventura or anywhere else in the state, and you can shop without having to establish an account. And so just in closing, there's lots of additional information. This is a very complex law. People have lots of questions. Our center website is here. Covered California's website is here, and it's coveredca.com. And it's important to type it in that way, because if you do Covered California or coveredca.org, you're going to go to different websites that look something like the exchange but aren't really the exchange. And the other two websites I suggest for more information, Kaiser Family Foundation has done a wonderful job of providing information that is not only easily accessible, but very easy to understand. It's not written for a technical audience at all. It's really written for a general lay audience, and they are a tremendous resource for information about healthcare reform and the Affordable Care Act. And then finally, I recommend that you visit the U.S. government's website, healthcare.gov, although you won't be able to do comparison shopping the way you can in California. So thanks very much for your attention.
Mike, can we turn the house lights up just a little bit? As we're working on some of the technical aspects, can we give another round of applause to both Gary and I mean, I have been in healthcare for 25 years and have been following the Affordable Care Act for years, and I'm not sure in a 30 to 45 minute session I have ever heard more complex information presented in both understandable and practical ways. So again, to our two speakers. In the remaining time we have, there are some questions that I'd like to ask, and if any of you have a burning question that you would like to have addressed, please write it down. There'll be some ushers coming up and down, and we can bring those to the front. But first I'd like to address this to maybe perhaps Gary and then Jerry. As a hospital administrator and also as a public health academic, when both of you think and reflect about Obamacare in its entirety over the last several years, what are the 1, 2, or perhaps 3 things you like best about the current law?
Well, I'll start. I think first of all, there is an attempt to provide insurance for everyone. As was pointed out, it has fallen short of that, particularly in other states other than California. So that's a very good thing. Secondly, I like the idea of an emphasis on prevention and wellness. And thirdly, to try to coordinate care better so we can strive for outcomes, and as opposed to more the episodic care that some communities have. Those would be the ones that I would call my attention to.
So I think that the aspects of the law that I find most favorable are the fact that it establishes subsidies for low and middle income families to buy health insurance in the private market. I personally think that an expansion of Medicare for everyone is a more effective mechanism of providing universal access in the United States. But politically, I don't think that there is support at this point in time for that type of intervention. So this is a very moderate attempt to build on the current system, largely on the private insurance system, and fill in the gaps. And given that that's where we are politically, I think that establishing subsidies, which is something that I was trained 30 years ago by some relatively conservative economists at the University of Pennsylvania, who believed that, first of all, the markets were the only way to improve healthcare in the United States. And secondly, always sort of wave their hands at, well, how do you make healthcare more affordable for low-income individuals? And never really got a satisfactory answer. The only way to do it is through subsidies. We could make we could make insurance affordable for everybody tomorrow if we were willing to provide 5 visits and 2 days of hospitalization. And that's a policy that nobody in this room wants. So that's the way you make healthcare affordable, through the insurance mechanism. You cut the benefits so severely that it's affordable to everybody to pay the premium, but the benefit is worthless if you are actually sick. So the market is not going to find a magic solution to producing comprehensive benefits that actually are meaningful to people when they get really ill, and also make that affordable. Just like we can no longer make a safe automobile for $4,000 a year. The Yugo was an attempt to do that, and how many Yugos do you see on the street today? None. It's because it was a poorly made car, and nobody wanted it. And the only reason that junk insurance survives is for the reason that Gary showed in that slide. If 50% of the people are currently healthy and low users, a policy with 2 days of hospitalization a year might be very desirable, especially if you believe you'll never be sick. So I like the fact that we have subsidies, that we've said that insurance needs to be more comprehensive, and that the only way to make it more affordable for lower income families is to provide direct subsidies for them to purchase those policies.
Now I have a follow-up question for that. Both of you referenced the fact that the sickest few members of our society tend to spend the most amount of resources for all of us. Do you see that the Affordable Care Act, Obamacare, will be leading to rationing of care for those individuals?
I don't think it'll lead to rationing in the sense that services will be taken away. Rather, I think that the idea of providing better coordinated care for the population, which we call population health management, is the way we're going to be able to provide health services at a lower cost. It is when we fail to do so that the cost of care goes up with unmanaged care, emergency room visits, unnecessary hospitalizations, and so forth. So I think it's just the opposite. I think that for the sick population, to focus on them, to provide additional services, is the way, ironically, to reduce the overall cost of healthcare.
Yeah, I think I agree completely with Gary's points, and would just point out too with that graph that the highest users are, what we really want to know is, are they persistently the same people year in and year out? If they are, then more effective management of high-cost patients is what we need to develop mechanisms to do that. And there is some evidence that there is a certain portion of the population with multiple chronic illnesses who year in and year out are expensive. So we need to do a better job on that. But there's another significant portion of those high-cost patients, which are any of us who happen to have a bad event in 1 year. All it takes is a week in the hospital or 10 days in the hospital to get into a six-figure bill. And I'm not talking about charges, I'm talking about the real cost of care. And Gary will appreciate the difference between charges and what the real costs are. And the point is that the costs become astronomical very, very quickly. So we can reduce the likelihood that people are going to end up with expensive hospitalizations if we have more people insured who are getting regular care and not showing up in the ER or in the hospital because they haven't had the resources to manage their own health.
Another follow-up question is, having both of you said what you like best about Obamacare, about the ACA, could you please, if you can't politically state so, what are the 1, 2, or 3 things you like least about the ACA as it is currently written?
Well, this will sound like I'm whimpering as a hospital administrator, but I am concerned about declining reimbursements. In order to make it more affordable, there has to be either a reduction in utilization or a reduction in payments to hospitals and physicians. I'm concerned about that. Specifically, I'm concerned about, as was shown on the slide, with a bronze plan, as an example, the deductible is very, very high. And we've already experienced with the so-called high deductible plans that have existed in the last few years, that when somebody does come to the hospital and has modest means, that means that is a bad debt to us or charity care and so forth. So we believe that that's going to escalate, that we're going to be providing care and our costs are going to go up, and the affordability part of it is not going to be there, because a family that buys the bronze plan or an individual is doing so because they can't afford the high deductible. It's ironic, but that is what we see. And lastly, I think that I wish the law could be have been debated a little bit more extensively and so forth. The example was given of the individual mandate in the first year at least of the 1% or 95%. That is far lower than the cost of a monthly premium. So there's little incentive for an individual to buy insurance. So I think the way it's currently structured, we are going to still find people that are on the sidelines. The intent was everybody would be insured, but that's not going to happen. So as a healthcare provider, we like some parts of it, but we think reimbursements are going to go down and our bad debt is going to go up. And whether that was an intended or unintended component of the law, it's a reality that we face.
So I said that what I liked were the subsidies. What I don't like are the level of the subsidies. I think if you're going to go to a subsidy-based system, then what I personally would have liked to have seen are actually larger subsidies. This, in the individual market, now anybody who buys insurance in the individual market knows this, you're paying the entire premium. The vast majority of us get our insurance in place of employment, and the employer is paying a large share of the premium. And what that means is that on a percentage basis, that I pay about 1% of my income for health insurance because the UC system pays such a large portion of the cost. According to the one slide that I showed you, families in the exchange will be paying up to 9.5% of their income. And those for a family of two, that around $50,000 a year, it's almost 10,000. I'm sorry, it's 10% would be about $5,000 a year, but 10% of their income for health insurance premiums. I would have liked to have seen those premiums make a bigger dent in the cost, the out-of-pocket cost. In other words, that they'd be even more generous than they are. And that was a political compromise to make the bill more affordable. It's still very expensive over the course of 10 years. And I think that in order to make it politically acceptable, the subsidies were modest.
A follow-up question from somebody in the audience asked, can doctors, and I'm going to add, can the hospital choose not to take on bronze patients but accept only higher medical levels of patients?
Sure. No, a physician or a hospital can elect not to contract with one of the plans. In our area, for the Ventura area, the exchange will include Blue Shield, Blue Cross, and Kaiser. Those are the only three choices right now. So a physician can elect not to accept any of those plans. A hospital can do the same thing. But if a physician accepts Blue Cross or Blue Shield and so forth, or a hospital does, then they must take that patient. They cannot choose between a bronze or a whatever plan, as I understand it.
Another question is, will the ACA impact the local and Southern California job markets, both in the general community and in the medical communities, and how will that be impacted?
Well, let me start. So healthcare is one of the few industries in the country, and certainly in California and Southern California, that continues to experience growth year in and year out. UCLA forecast has shown consistently, even through the Great Recession, that the one sector of the economy that continues to grow is the healthcare sector. Is the Affordable Care Act going to result in faster growth? It's a little unclear. There's certainly going to be more people with insurance, and we know from numerous studies that when people go from being uninsured to being insured, that they use more services. The question is, are they going to be served by the current supply of doctors and hospitals, or will there be some expansion? In the short term, you cannot quickly expand the number of doctors in the United States or in California. Whether or not this leads to an expansion or growth in the healthcare industry, in the long term, it more than likely will. In the short term, it's difficult to rapidly expand the supply. With regard to jobs, it creates a variety of incentives, and we're really going to need to see how these all sort out. But one thing that's clear is that for people who have employment-based insurance now, that the idea of hanging on to a job because you need insurance through your place of employment, it clearly unlocks people from their current jobs. And I think most labor economists feel that this may be the most important advantage of the law, is that it allows a mechanism for people to leave a job, become self-employed, and still have the opportunity to get affordable insurance.
This is an interesting question. It sort of touches me as a bioethicist. Does the Affordable Care Act safeguard the privacy of my medical records and my personal information? And I'm assuming that you mean for American citizens and not, let's say, Chancellor of Germany or our allies. So does the ACA safeguard the privacy of our personal information?
Well, the ACA doesn't address that specifically, but there are other federal laws that do. HIPAA is the law that protects the privacy of our medical information. And I know this all too well because we receive confidential information, or what's known as specifically protected health information at UCLA. And we have a very high level of security that we had to institute in order to even receive the data in the first place. So those laws have been in place. The ACA doesn't do anything specifically to change or adjust HIPAA requirements, but those are still in place.
You know, we've gotten, I think, no less than 50 questions from the audience, which is terrific. Unfortunately, we're going to have to cut it to 2, but I will speak in a second that we will be having another session in 3 weeks, and I promise to get to at least 1 or 2 of those at that time. So a question I'd ask to our speakers: if the Secretary of Health and Human Services, Kathleen Sebelius, called you after tonight's session, and although she would probably want you to testify in front of Congress on her behalf in 2 days, but supposing she asked you a different question, and that would be, what changes or improvements would you make now to the ACA?
The immediate change, so obviously the federal website is in the news, and with good reason. They've got to fix that website. And the end of November, I think there should be daily White House briefings on what progress is being, and there should be working literally 24 hours a day on this. The fact that that wasn't done this summer is, I will just say, personally shocking to me that with so much at stake, that this was not done. We've had 3 years to prepare for this rollout. Everything is riding on this, and for it to be rolled out this way is not only an embarrassment, but it is a disservice to all Americans. Whether you support the law or not, it's just a disservice to the American people to dump a website like this, ask people to shop for insurance, and have the site be completely dysfunctional. This is a great country. We've built many great things over the years. The fact that we can't, in the 21st century, create a website should be an embarrassment to everybody. So that's what I would tell Secretary Sebelius.
I would agree that confidence needs to be restored. I think the website has been somewhat of a lightning rod on that. If I had a chance to talk to Kathleen Sebelius, I'd also ask her to re-examine some of the rules that Medicare is applying with respect to observation status. We have patients in the hospital, many, about 20 to 30 a day, that are in the hospital overnight as outpatients. Some of them stay 2 or 3 days, and we're paid a quarter of what an inpatient stay would be. We think that's wrong. The patient has to pay more money out of pocket. The hospital gets less money. It's frustrating for everybody, and it's becoming a societal issue. That's a technical area, and again, I'm whimpering, but that's what I would tell her.
And just to be clear, that's not the ACA that did that. That's just Medicare has. So there's lots of things going on at the same time.
Yeah, I think we're all family, and whining is acceptable.
I said whimper, not whine.
I stand corrected. The last question that was offered from the audience is a provocative question. Obamacare, or the ACA, even the name Obamacare, is extremely political. What, if anything, will ever control the tension and partisanship surrounding healthcare reform? And please answer in 10 or 15 seconds.
I mean, if I knew the answer to that question, I'd be a political wizard, I guess. I mean, the polarization in the country certainly is at a level that I've never experienced in my lifetime. And I was a child, but I grew up in the 60s, and The 60s were a highly polarized time in our history. I think that the focus of discontent on this law will subside, though, within the next year or two, because I think that the real benefits of the law are going to be apparent to millions of Californians and tens of millions of Americans in about 18 months, as we go through a cycle. So all of the hoopla about the website not working, it's an embarrassment, but it will be fixed. Maybe it won't be fixed as quickly as it should be, but a year from now, that will be working smoothly. People will have insurance benefits. People who get sick will not lose their health insurance because their companies decided to cancel them. People who get sick will not be paying higher premiums because they have a pre-existing condition. People who lose their jobs will have access to health insurance in the exchange. So there are benefits that none of us want to use. I don't want to be sick a day in my life, but it will happen again. And when it does, what I need is the protection that's available, just like the protection that I have with my car insurance. I hate sending that payment every year to my insurer. I'm a safe driver. I've never had an at-fault accident in my life. But I was almost killed last year when a wheel came flying off of the truck on the freeway and smashed into the roof of my car and knocked me unconscious. I don't know how I stopped the car, and I'm still asking my wife and daughter how that happened, but the point is we walked away from that. I did not ask for that to happen, but life happens to all of us. Bad things happen. People get cancer, not because of their lifestyle, but because bad things happen. And so the most we can do is hope that we have adequate insurance so that we can get the appropriate treatment that's available. Hopefully we can be cured, and if not cured, have a high quality of life, and not bankrupt our families because we have hundreds of thousands of dollars in medical expenses.
I think the polarization in the country is something, I think that's among our biggest problems. George Washington argued, don't have this process, and within a couple of years of his inauguration, first one, they started to develop. I think as a result of that, Obamacare, or the Affordable Care Act, was both a triumph and a tragedy. A triumph in the sense that 6 previous presidents tried to put in some type of legislation to address the issues. I think that was a triumph. The tragedy was, this is the first piece of major legislation that did not have a full bipartisan debate. And I think what we ended up with is short of what we as a nation could have had. I believe that the systems to the right that Switzerland and Germany have, that is a market-based system, different from ours, is better than what we have ended up with. I think also that the system that England, United Kingdom, Britain, and Canada has is ultimately better than what we have as a hybrid system. One is a tax-based system, and Medicare is a component of that. One is a market-based system. And I think we are trying to mesh together something together. And I think that had we been able to come together without the political warfare and examine which type of system would be better, we could have created a better system than what is here. And maybe that is something that we can talk about in the future, and that's maybe something we can move toward. But I think, as Dr. Kaminsky said, that the subsidies were not right. I share that the level of the individual mandate is off comparison. There's many things like that that I think we could have done a lot better, but because of the political polarization, we fell short of it.
Before we conclude tonight's session, I'd like to invite both our speakers to briefly summarize in the next 1 to 2 minutes their overall state of Obamacare in the end of October 2013. You each have 1 to 2 minutes, and perhaps Dr. Kaminsky, it's your soapbox.
All right, well, I've already been on the soapbox a few times in my responses, so I will keep my remarks even briefer. I think that where we are right now is, if I were, as a professor, I can't help but grade people, including myself. So I think right now where we stand, it's a C, maybe a C minus. Gary, I think, summarized my feelings very well just a moment ago when he said, we can do better. We can do better in a lot of areas. I am satisfied, however, with the fact that this is, I see the Affordable Care Act and Obamacare as an interim step, and it was an important step for us to take as a nation. There are way too many people who suffer the consequences of being uninsured, and a disproportionate number of those Americans are poor or near poor. The working, the lower middle class, who just happen to work in jobs that don't provide health insurance benefits and go without because they can't afford it without assistance. So I think that it was an important step, but where we are in the process right now is the implementation has been very rocky.
I agree with what Jerry said. I think that this is an attempt at addressing the issues. The current situation is simply unsustainable. Irrespective of your political views, irrespective of everything else, we would simply go to a point where the cost would become less and less affordable for the average American. We would still be uncoordinated in our care approaches. And so while this is not perfect, I've already outlined that, I'm not going to repeat that, it's far from perfect, and I think other countries have done it better to the right and to the left of us. But we're at least moving in the right direction. I just hope that we can have civil dialogue and have more planning and real planning than politics take us from here. Having said that, I think that's going to be very challenging because of the polarization.
You know, it seems to me that Dr. Kaminsky gave healthcare reform a C minus so far, but I think, speaking, I hope on all of your behalf, I think we were just entertained with an A presentation from Thank you so much to our keynote speakers, Dr. Gary Wild and Dr. Gerald Kaminsky. I'd also, again, like to very much thank the Board of Trustees and the administration of Community Memorial Hospital for hosting tonight's event. I would also, again, like to have a shout out to Mike Ellenson and Mary McCormick for really doing a wonderful job tonight. I invite you to join us in 3 weeks for part 2 of this series on healthcare reform, which will be on Tuesday, November 19th at 5:30, also here. The title for that program will be Exchanges, Mandates, and Marketplaces, oh my. A practical primer for patients and families about the difficulty of navigating through the changes in healthcare reform. And finally, as a clinical physician, I'd like to close with something medically clinical. Caption for those in the back. The caption reads from this physician, "The ringing in your ears, I think I can help." We at Community Hospital also want to help, and we look forward to seeing you back in 3 weeks for our second session on healthcare reform. My name is Dr. Jim Hornstein. Thank you all so very much for coming. Have a pleasant evening.